two sets of minutes whenever you are ready.
So moved that we approve the minutes of Tuesday, March 13th and Thursday, March 15th.
Is there a second?
Second.
All those in favor?
Aye.
No opposed? Thank you. We have a new website. The address is www.gmcboard.vermont.gov. And I think it's right there. First on our agenda today, we have Barbara Cimaglio, the Deputy Commissioner of Alcohol and Drug Abuse Programs from the Department of Health. How are you?
I'm good.
Take your time getting ready, because any stalling is good for Anya.
Oh, I like it.
In Anya's
We were going to
defense,
read the minutes. No, I'm kidding.
her calendar gave the wrong location.
Yeah. She's.
Comments were blocking the screen.
I fixed it.
Is that the right one for forward? I just wanna
If
make
you
sure I
wanted
know.
that, or you could use these down here.
So this one is forward. Okay.
Or page down. Okay.
I just wanted everybody to be able to.
Right.
Just want to make sure I knew how to use the machine.
Actually, I'm going to take a minute as we're setting up. This is the first of probably will be a total of 6 or 8 different meetings on mental health and substance abuse that the board's going to hear over the course of the year. We were fortunate to get Barbara first, so thank you.
Great. Well, good afternoon. I'm glad to be with you here today to give you an overview of the alcohol and drug abuse programs that are part of the publicly funded system in the state. And you should have some handouts that I'll be referring to along the way. And I've also brought some of my staff, so if you have questions that are beyond some of the overview, I tried to make sure we have people here that could answer more in-depth questions for you. I also wasn't sure exactly how much each of you knew about the system, so I'm starting with pretty basic information. I tried to cram in sort of a lot. I'll try to go over some of the background stuff fairly quickly so we could have more time for things that are more substantive, I guess, if you will. And I'm sorry, I don't know your protocol, so if there's discussion involved or anything like that, is that an opportunity, or is it mostly presenting? How do you do questions and answers?
Typically it's fairly free flowing.
Good. Okay, that's
before you
great.
switch from a particular slide, someone of the board members may have a question or seek clarification.
Okay.
And then, wherever it goes from there.
That would be great. Okay, I just didn't know if it was, if I should assume formality or a little more, question and answer.
No, assume sort of informality.
Okay,
and,
that's fine.
And go from there. We want to understand.
Good. Okay. Well, I feel free to interrupt at any point. Then I guess is the comment, because Okay. So.
Hi there.
Hi. Oh, see, I took.
I'm sorry. My
Hi.
calendar told me to be somewhere else.
My reign as king of the world
Oh,
officially
thank-
ended. 1310 for all of you in the military.
Doing beautifully, Al.
Thank you.
Hi.
Hi.
welcome.
How are you?
Thanks.
Okay, so a little bit about the substance abuse system, the public system. This is just our statutory charge, and I'm not going to go through all of these, but it basically gives us the authority to operate a comprehensive program from prevention through treatment. And also we do Project Crash, which is the drinking driver rehabilitation program. We also approve the publicly funded treatment programs, so you have a little brochure that lists all of the treatment providers, just for your reference. We are part of the Agency of Human Services, and this program sits in the Health Department. which is one of the agencies of the Agency of Human Services. Some of this will be a little hard to read, and I apologize for that. But hopefully on the handout, you're able to see it. As has the governor, we've all done our strategic planning, the Agency of Human Services and the Department of Health. So our mission is to protect and promote optimal health for all Vermonters, and our vision and goals are listed here. So that's just to give you context that we are in the context of public health, and our goals are consistent with the public health goals. I'm, again, not going to go through this, but I wanted you to have information about the alcohol and drug abuse program's vision, mission, and our themes and strategic components. Again, I think what this says is that we are accountable, community-based, and that we are comprehensive from prevention through recovery. And strategically, we organize ourselves by prevention and early intervention, treatment and recovery, and then the operational components that help us get those services out. We don't provide any services directly ourselves when it comes to treatment. All of our work is done through grants and contracts with community-based treatment providers, which we call our preferred provider network. We do have prevention staff who do work in the local district health offices, but for the most part, we do our work through community grants and contracts. So just important to note that. Again, we do take a public health approach. We focus on change for the entire population. We do have a prevention strategy, which we'll be going into a little bit more. And we, of course, have looked at the patterns of use of alcohol, tobacco, and other drugs, and the consequences of that use, and have developed our strategies based on that data. And established our priorities, also looking at that data. So again, strategic directions, mostly so that you know that this is all in place, and the grounding from which we work. One of the things I would mention, one of the things we are focusing on this year in the health department in a general way is health disparities. We found that, as we look at some of the data, we note that there are some different patterns of health and wellness among different populations, and so we are trying to look at that across all of our programs, but specifically here talking about alcohol and drug. We may see a little less difference between populations in this area, but we are looking at how we can do a better job of making sure our services are tailored appropriately for people with health disparities. So now moving into our outcomes, increasing the proportion of the total population who needed and received specialty treatment for abuse or dependence in the past year. This is also one of the federal outcomes that we've also adopted. So what we do is we look at the number of people in need, and I'll be talking a little more about that. And then our goal is to improve access to care so that we're serving a higher percentage of the people in need. That's what that one means. It's worded a little oddly, but we adopted the federal language, and so it's a little tricky to understand. The next one is to reduce the proportion of individuals engaging in binge drinking. I'll give you some data in a little while that this is one of our major problems in this area. Reducing the past month use of alcohol and illicit substances among adolescents. So specifically, our prevention work focuses on adolescents, knowing that for young people who start use of alcohol, tobacco, and other drugs early, they have a disproportionately enhanced chance of having a lifelong problem with alcohol or other drugs. So early prevention and early intervention becomes an important outcome. And then strengthening and expanding statewide supports and infrastructure necessary to promote effective community-based substance abuse prevention and treatment services. As I mentioned, we don't do a lot of our work directly. We do it through supporting an infrastructure that allows our community partners and providers to do the work. So that's just an overview. I guess any questions on overview before we go a little more into the problem? All right. We have a lot of data. I've tried to select some key data that would give you a snapshot, but we certainly would be happy to share more with you if you have an interest in getting more complete data. We've tried to pick from some of our national surveys as well as some of our local data. And what this tells us is that the picture in Vermont shows that we have high use of alcohol and illicit drugs across the state. Nearly half of all children live in a household where a parent or other adult uses tobacco, drinks heavily, or uses illicit drugs. And just to be clear, alcohol, tobacco, and other drugs we look at all together because they're all addictive substances and they all have serious health consequences. Our strategies may be different, but we look at all of those together. Specifically in what I'm referring to today, we'll lean more on alcohol and other drugs and not as much on tobacco, except for in talking about some of the data. Illicit drug use is higher in Vermont than both in New England and nationally, driven largely by the high rate of marijuana use. We see that when you see data about illicit drugs in Vermont, the biggest element in that illicit drug category would be marijuana. And that's the federal definition. They put all of those together and then they break them out separately. But when you see those national surveys that show that we're higher, that's what's really driving that number. Marijuana, tobacco, and alcohol are the major challenges. And again, that's because when we see young people beginning early use of those three substances, we know that it's that their chances of continuing to have health problems related are increased. Again, for the younger group, marijuana and alcohol, the predominant drugs in the 12 to 17-year-old range. And as I said, if they use early, they're 4 times more likely to meet the criteria for abuse or dependence than those who started using at an older age, if they use at all. And so that's a little bit about the population and where the problem starts. But then I think of concern, particularly in this setting, is that fewer than 20% of those in need of treatment in all age groups receive help for their addiction. And many people come in to the treatment door because of some other issue, driving under the influence, ending up in the hospital because of an accident, injury of some kind, domestic violence, some other thing, or ending up in corrections because they've infringed somehow on the law because of their drug use or alcohol use. And so this area is still one where people feel ashamed and embarrassed to talk about their issues and to ask for help. It's not like going to the doctor when you, have a pain in your shoulder. It is something that generally is very difficult for both the patient and the physician to talk about. And while we've made a lot of progress, we know that we're going to have to make a lot more progress in being able to discuss these issues related to drug and alcohol abuse and addiction if we're going to get ahead of this problem, because it persists because it's in the shadows, you know, and the more we're able to bring it out of the shadows, the more we know that people will feel that they have the support to get help or to ask questions as children. I think a lot of the secrecy that goes on and the hiding of use is not something that helps in trying to get ahead of this issue.
So you talk about the readiness, the denial.
Yeah.
Of that 20%, aside from that group, which is probably a significant percentage, what percentage would be access to services or
Right.
coverage of services?
Right.
You know, how do those three kind of work together?
It's an important question, and I think in a general way, I would say access to outpatient services is pretty good all around the state. Access to residential treatment is limited to, certain number of beds in 3 locations, basically, around the state. And we have waiting lists, and I'm going to talk a little bit more about that later. And then we are now challenged with trying to improve access to medication-assisted treatment, methadone treatment for people with opiate dependence, which has been a very large access problem. So I don't know if I can say to a percent how it splits, but there's definitely access issues along with attitudinal issues, readiness issues, and so forth.
Barbara, this may sound like nitpicking, but it's not. I suggest you change your heading on that graph, on that chart that you're just showing. It reads Vermont trends and numbers, and of the 5 points you make, there are no trends. There is no trend. And I know you get into a little later, but just to be clear.
Sure. I will. Our group is so noting.
Do you think there are coverage issues? I mean, do you think there are some payers that are less likely to cover a fully functioning recovery program or a harm reduction program? Aside from Medicaid, do you think that that's out there?
We have parity in Vermont, and I think for the most part, there is coverage. How extensive it is another question, and I think those are good things to look into. I know the federal government did an analysis of insurance coverage in preparation, for the work coming that they're doing, and they found out while there is coverage, when you look at what it actually includes, it is often outpatient but no follow-up, or limited residential but no recovery support services.
Right.
So I think there still is a challenge there as well. A little more about who the population is. Many individuals presenting have polydrug abuse, so just to say that we see very few people who come in for treatment that just use one substance. Most of them are using multiple substances. And we see that there is a high percentage of co-occurring mental health disorders. Again, a lot of the people that we see in the substance abuse treatment services, the co-occurring disorders are not necessarily the serious and persistent mental illness, but they are other mental illnesses, depression, anxiety, and the like that co-occur. So it's very complicated, even using the term co-occurring. I think we need to be careful to explore that, because it isn't just one thing. And to say someone has both an addiction and a mental illness can mean a variety of things, and can mean that they need a variety of levels of care. And then finally, our data show that about half the people that we see in the public system have some involvement with the criminal justice system. So very high overlap there.
Can I sneak a question in there?
Sure.
Earlier today, we met with HHS and Medicare, Medicaid people from the federal government, and part of me just always wanted to be able to say that, so I did just then. And one of the questions I asked was about the criminal justice system and its dovetailing or interaction with recovery, because as an employer, it's very hard to deal with reentry.
Yes.
You know, so maybe not today, but possibly you could think about how we could make that work better. And I know a lot of people think about it a lot, but how could we actually, you know, make the two different systems understand each other, and then the workplace, because it's hard on the employer
Right.
When you want to do something good or well to get it done.
Right. That's a really important point, because I think when we talk about healthcare and when we talk about addiction in the context of healthcare, that's only one component. Most of the folks that we see in our services will also need a lot of social support, kind of, you know, whether it be job readiness or life skills. And many of them are also involved in like the child welfare system. So while it's important for them to get the health part of this service, it's also really key that it be connected up with those other supports in the community.
What I normally see is it's like it's a connectivity that is uniquely designed to be a catch-22 situation. You get paroled, but you have to have a safe place, and that's a term. That's not just, you know, like
Yes.
safe according to your mom.
Right.
A safe place to live, and then you have to have meaningful employment,
Right.
and then you might have your wages garnished because you might have a child that you need to support, and so you get out of jail, you try to find an apartment, you don't have a job, you can barely get an apartment, then you get a job, and then your apartment's deemed not safe because you couldn't afford one in a safe area anyway, so there's always going to be a case of beer on the porch from some other tenant in the 4-unit apartment building. So then they come and arrest you while you're at work and humiliate you in front of everyone you know, because you just got out of jail after ruining every relationship in your life. And so that's what I average about 4 people a summer that get arrested at work.
Yeah.
So it's not a small thing.
It's very challenging, and I think you're just underscoring how challenging it is. But I think the importance of having holistic approaches in the
Yeah.
community, so that you as an employer and the social services that are helping the patient, and if they're in some kind of treatment, that somehow they work together to help
right.
the person make progress and not just keep spinning around.
Right.
Yeah,
Thank you.
yeah.
Barbara, the implications of this consumer profiles piece are really huge. When you combine the 2/3 have a co-disorder, and the fact that 49% of people presented for treatment have involvement with the criminal justice system, and you start to apply those statistics to corrections, and I just did a little bit of rough arithmetic here, but it tells me that we have over, well, starting from the premise that 80% of prisoners have some kind of alcohol or drug difficulty, though we've got over 1,000 people in our jails that need this kind of work, this kind of treatment. So George, I guess what I'm suggesting is that I would really like to hear from those folks what's happening in that world. That's a big number.
I would agree. I mean, that's a big part of what we do, is we work with corrections, and those partners are, you know, hand in glove. So,
But the whole thing comes back to your charge, your mission. And then, you know, what we want to test is the word effective.
yeah.
You got the word effective in the mission. How effective is all this work?
I
Okay.
think that's the ongoing challenge and
Yep.
question, yep. So a little bit more specific on the need. And I think the way we do need estimation is based on the National Survey on Drug Use and Health, which is a federal government survey managed by Health and Human Services. And they have formulas for how you calculate need and how many people are expected to seek treatment. So we've used those formulas to apply that to Vermont. So you see about 8.3% of the total population would be in need of substance abuse treatment according to the DSM diagnosis. About 13,000 would be expected to seek treatment, and then you see the number who actually received treatment on the bottom. So we're doing better than a lot of states in terms of just getting people to the door, but we've still got a ways to go there in terms of the gap, particularly, as I mentioned, in the medication-assisted treatment, where we have a lot of people eager to get that type of help that can't yet access it.
And I promise I won't overdo it here, but in terms of proportion, initial people in need of substance abuse, that equals about the population of Washington County, the entire population. And those number of Vermonters in need of substance abuse, it's about the size of Barry. I mean, we're talking big, serious, dangerous numbers here.
That's absolutely correct, and I think it just underscores the extent of the challenge in this area. Yeah.
Does this type of model include the prison system, or is it done?
It's a population
So it's
model, so it's based on the total number of people in the state. Yes, it
Okay.
includes
Yeah,
everybody.
okay.
Mhm. Yeah. So a little more description here. Prevalence data by age. This is alcohol dependence. So this is just showing over time the number of people, or the percent of the population by groupings that have alcohol dependence, again from the National Survey on Drug Use and Health. So we see our highest number of people who meet the DSM criteria for alcohol dependence are the 18 to 25 population. And we don't see a lot of movement, you know, in the range over time. Again, this is same from the federal data. The binge alcohol consumption past month consumption among 18 to 25-year-olds. You'll see that the dark red is the highest percent of people who say that they have consumed alcohol. Binge drinking is defined as 5 or more standard drinks in a sitting. And New England comes up high, but Vermont and New Hampshire come up right on the top there. Prevalence data by age and drug dependence. Again, these are which substances are used the most that contribute to the drug dependence. We see alcohol is still the number one, followed by a rapidly rising trend, the dark blue, for heroin and other opiates. So that is why we're so concerned about those substances, because we see this rising trend that is outpacing our ability to keep up with having treatment available.
Barbara, what's the NSDUH?
That's the National Survey on Drug Use and Health, the federal survey.
And that's an annual?
Yes, and these are in these are in-person interviews. I mean, they do this across the whole country. So this is the gold standard data that we have for substance abuse, drug and alcohol use.
So they go out and randomly sample in
Random,
person?
yes, and the whole protocol is up on their website if you're interested in how they do it. It's a quite in-depth process for them to compile this survey. And then periodically, they do drill downs of state data. So they have annual data on the whole population, and then as they have enough data, they do it state by state. So it's really pretty comprehensive. This is all Vermont emergency room discharge rates by specific substance diagnoses. And you see here the green line is alcohol. So at the emergency room, rate per thousand, the most prevalent is still alcohol in terms of contributions to the emergency room burden. And that's from the Uniform Hospital Discharge Data Set.
How do they code for polydrug use?
Well, I think coding is part of the challenge, that it isn't as clean as one would want. So, some of it's up to the judgment. Who's ever doing the coding, they decide, is it alcohol, is it opiate, is it, they have to pick. Okay, so now I'm just going to go through the services that we deliver. Prevention.
Just to do a time check on us,
Yep.
we have another presentation this afternoon. I know Al and I have to leave at 3, so.
Yeah. So we're going to go through these, and again, happy to give you any follow-up information that you'd want. This just is a diagram that we use that basically, I think, underscores that we hope that we're doing more work on the bottom of the pyramid, which is prevention and early intervention, before we get to that smaller part of the people who actually need treatment. But it is important that we have strategies for all levels of use. And this, I think, demonstrates the types of services that we deliver, starting with primary prevention down to recovery. I'm going to talk a little bit more in depth about prevention. We use a public health prevention approach. We have community grants that go out to a number of communities, and they all revolve around this model of starting out with assessment, building capacity, developing a strategic plan, implementing evidence-based programs, and then monitoring or evaluating. We're hoping, as the community health teams and everything that goes with those get in place, that our model actually fits nicely into the work that they will be doing, and offers some tools for them. This is just the listing of the kind of services we support in our community prevention system. I mentioned coalitions. We do a variety of education, from family education to student assistance in schools. We support a clearinghouse that distributes information, and we have staff that are regionally placed, all for prevention. We do receive a federal block grant for prevention and treatment of alcohol and drug abuse, and so a lot of what we do is actually supported by that federal block grant, which is about $5 million a year that comes to Vermont. We, again, comprehensive strategies, from information dissemination to community mobilization. And this just gives you a little, the chart shows the breakdown of what communities are actually engaged in who are doing prevention. And when we talk about prevention, it's less about screening in this context, and it's more about community building and community programming. And we're trying to move more people into the policy change arena, where they're actually looking at what policies in their community support healthy behavior. So, for example, we did a series of grants this past 2 years called Healthy Retailers, where mom and pop stores, convenience stores, could get grants to look at how they were advertising in their store, how they were placing alcohol advertising, tobacco advertising, and how they could reposition things so they were showing healthier foods and options closer to the front of the store, like the dish of bananas you now see when you go into some stores. So through working with the Healthy Retailers grants, we both helped educate the retailers and also encourage them to look at their own policies and what they were communicating in the community. Our outcome measures that we look at for prevention have to do with use, and you can see that we are moving in the right direction, albeit more slowly in some areas than others. And we've seen some nice decrease in the alcohol use among high school students.
And what do you attribute that to?
Well, we'd like to attribute it to the prevention programming that so many of our communities are engaging in, and the fact that we've been focusing on this. We had a very large federal grant that ended last year that allowed us to pretty robustly support our communities, and a number of them had grants to particularly focus on these areas. So,
What kinds of things did they do?
well, there are a lot of different evidence-based approaches, and they had to choose from among those, but they all focused on environmental change related to alcohol use and marijuana use primarily, including binge drinking, so these particular areas. This is a little bit busy, but just to show you the trends over time. The way we're moving in general, and again, we're seeing some movement in the right direction. Where the stars are placed, we're seeing some significant reduction in use, and this is from our Youth Risk Behavior Survey, lifetime use, 9th to 12th graders. So I think we've covered most of that. I think the important point I would make here is just that historically substance abuse services have been very separate. They've not been part of the medical world or health care. They've really been a specialty system funded primarily by grants and by Medicaid, and Medicaid mostly for treatment. So you know, we're evolving now to be more into the healthcare world. And this is how we see what we're trying to achieve and the way we look at our system, that it's a recovery-oriented system of care where we're trying to make sure that people have access to services, but also get recovery support in their community. These are the core treatment components. Again, I know in the interest of time, I'm going to move quickly through these, starting with screening and treatment development, I think pretty similar to other conditions. This shows you how many the people treated in fiscal year 2011. I wanted to make sure you knew how many people were actually treated in the public system and what types of treatment they get. So the majority of people get outpatient treatment, about 7,000, and then you can see it goes down sharply from there, as you would expect that most people are getting outpatient services. And this again is the people treated by substance of abuse and fiscal year. So as I've said before, along with the problem, we're seeing more people coming into treatment because of an opiate problem. And this just illustrates why is opiate addiction so much more of a challenge. The pink line is the elapsed time between age of first use and age at treatment for daily users of opiates and alcohol. And we see that people tend to come into treatment much more quickly when they've been using opiates on a regular basis. So the toll that they take on one is evidenced much more quickly. And so that's why we feel that the burden has increased so dramatically on our system because of the opiate dependence. Whereas the alcohol, it's much more spread out. You know, people use over time and they come to treatment over time, but it's not as dramatic. Waiting lists, this just shows our waiting lists for different types of treatment. The largest is for, we split between residential and medication-assisted treatment. This just also shows the trajectory of the number of people being treated with buprenorphine greatly increasing.
Could you expand a little bit on the characteristics of the waiting list? Is that list include, let's say, waiting list for other services? I just saw Bill Young in here, for example, for Maple Leaf.
Yes, that would be in the residential, the blue in the middle. I'm sorry, the little blue up on top. Thank you for the correction.
Would that include waiting lists for people in prisons?
This is reported waiting that the providers report to us, how many people are waiting. So it's from the perspective of the treatment providers, people who present and they have to put them on a waiting list.
What's your sense on how accurate this might be?
I would say we use it as a general guide. It fluctuates a lot, and we don't have a way to determine whether people are on more than one waiting list. We are required by the federal block grant to keep a waiting list information, so that's a feature of our block grant, that we have to report that to the federal government. So we covered that. Going into, I'd like to spend the last part of the time just touching on what we affectionately call the hub and spoke model, and you have a handout. On the hub and spoke, and it's, I'm not going to have time to go into all of the depth, but I think this has been work that we've been engaged in with the Blueprint and with the Department of Vermont Health Access. We're trying to take the principles of the Blueprint model and apply it to people with addiction, with addictive disorders. We're starting with the opiate dependence, and we're taking this on because we have been seeing such a great increase in the number of people presenting for opiate treatment. And we know that the way our system is constructed now, we have 5 methadone programs around the state, and they serve less than 1,000 people altogether at this current time. And we have an increasing number of people that are being treated, paid for by Medicaid, to the tune of, on the handout now, $36 million spent last year on buprenorphine, which can be prescribed in a primary care setting by a primary care physician, different from methadone treatment that has to be prescribed in a specialty clinic, federally approved and state approved. Much harder to be a methadone program. So when we saw that the access to methadone treatment has been restricted basically and very challenging for people to get that treatment, we've seen this spike in the number of people getting services from primary care for opiate dependence. The challenge there is that our medical providers are overwhelmed. They're saying, they don't have the supports to treat this population. They are not trained other than, very minimally to be able to treat this population, and they need help. And so we had a series of meetings with both specialty providers and general medical providers, FQHCs, et cetera, to talk about what could we do to address the need for this treatment that would better bring together our specialty care and our general care, our medical homes. And based on that, we've been pursuing this hub and spoke. So what we're proposing is that we would have 5 hubs that would be methadone programs and also be able to provide assessment, care coordination, technical assistance to other physicians who are working with patients, and care coordination, did I say that, and consultation. So specialty provider in the middle, and then extending out to Blueprint medical homes, FQHCs, practices who have a significant number of people seeking treatment for opiate dependence. And also then linking with all those other support services, whether it be mental health, family supports, pain management that also goes along with this. And our goal is really to take these dollars that we're spending, about $44 million, and make sure that they're structured in a systemic way to help us better achieve our outcomes, rather than having people struggling trying to get treatment and not having a coordinated plan, which is kind of what's happening in many places now. People are scrambling to find treatment, and the doctors are doing their best, but they're having a really hard time keeping up and managing these patients. So what we'll be doing is putting in a state plan amendment for Medicaid so that we can get the Affordable Care Act medical home 90-10 match funds to get this started. And we're beginning in Chittenden, in the Chittenden region, and in the Rutland-Bennington corridor. We will have a hub in each of those locations, and then a number of spokes. And the hub, on page 3 of the briefing paper on the Hub and Spoke initiative, it goes into detail about the staffing assumptions and the number of people that we would treat. And I think it's important just to note that the spoke would be based on adding an additional RN and licensed mental health substance abuse clinician for every 100 patients in a spoke site, so that there would be more adjunctive care to serve those folks. And on the back are some modeling that has been done by the Blueprint, basically showing how, I think we've got this. So that's the hub and the spoke, and this continuum is similar to other chronic diseases. I put it up here, that the ongoing care is delivered in the patient-centered medical homes. As specialty care is needed, that's accessed. And our hope is that that episodic care in a residential or hospital setting would be reserved for those who need that on a periodic basis, but that everyone would be centered in the medical home. And this is really pretty exciting. I thank you for your patience in kind of going through a lot of detail. But I think this is the most exciting part of where we're headed, is really starting to treat addictive disorders as other chronic diseases, to be managed, to have a center with a medical home, and the adjunctive services wrapped around that people need, and recognizing that this care needs to be accessible around the state. And we know that we can reduce some of the other costs in the high end by better managing the care that people receive. Yeah, this just shows this is the basic model of the blueprint. So we're just taking the all-payer model and applying it to this. Finally, and I'm not going to spend a lot of time going through this, but I've included some charts that show you the spending breakdowns so that you could understand the complexity and the composition. You can see on this chart here, page 40 on the handout, overall funding for substance abuse services heavily reimbursed by Medicaid and by our block grant and state funds, the ADAP grants. Small amount by third party, and DOC for the question funds about $5 million in direct treatment services under their umbrella. The bulk of our funding is for treatment, much less amount on prevention and early intervention. We'd like to see that change a bit, so we're able to do more on prevention. We saw when we had that large federal grant, and I gave you a handout, a couple of handouts specifically on prevention. We won't have time to go through them in depth, but I encourage you to take a look. We've just gotten our preliminary evaluation findings from our large 5-year grant, and we see significant reductions in decreases of use in the paper that our PIRE, Pacific Institute on Research and Evaluation, specific decreases in use of binge drinking, alcohol, and that was statistically significant. And that was one of our primary areas that we focused on there.
So Barbara, what stands in the way of making the 3.8% a lot higher?
Well, the primary source of our funding for prevention is our federal block grant. We get a small amount of state funds, but I think this is generally not a reimbursed kind of service.
So we
I'm
can't
hoping
spend Medicaid money on prevention.
we think that we might be able to do more there, but that has not been a source of funding for our prevention programs.
And the prevention programs that were under the grant, what happens to them now?
Well, a lot of them stop because we knew that we wouldn't have the funding to continue those. So we're trying to work at keeping at least a base level in all communities. But there is a significant reduction, and we don't know how that's going to leave us with these trends.
I've never been in a position to bring this up before, but you know how we dealt with tobacco abuse is our attorney generals went after the tobacco companies, which gave us money to begin prevention programs. Okay. Do you know of any place where a state or an entity was willing to go after the pharmaceutical companies that brought this upon us by formulating OxyContin in a way that I believe they knew it was going to be highly addictive, with a short-acting and a long-acting component, and falsely advertising that to physicians for many, many years? If we want to do, prevention programs are important now, and I believe that now they've reformulated the OxyContin so they've taken it, it's become a little less addictive, but it's out there.
That's right.
I mean, I've never been in a position to say this in a public forum, but I think that would be a perfectly appropriate approach. They made billions of dollars on this drug by thrusting it upon a vulnerable society. And now they're not taking any accountability for it at all. Is that right?
Well, I
No.
think it's,
No.
I know there have been some lawsuits. I'm not a
Yeah.
legal expert on that, but there have been some, and I know there have been some settlements.
why we
But
can't
have we
ask-
seen anything akin to what's happened with the tobacco companies? No, we have not seen that, nor have
Ask-
we seen that for the alcohol
The
companies.
richest industry in the country, we can't ask them to
Yeah.
help participate in a prevention program.
Well, I can't, but maybe you can.
I'll make one other comment and I'll stop, and that's that, I've been a family physician for a long time in Vermont, but one of my roles back in the mid-90s was I was the medical director at Day One.
Yeah.
And anybody here from Day One? So I know how difficult this is.
They're one of our preferred providers, though,
Yes.
so, yes.
I know. And I know that when you talk about dual diagnosis or co-occurring conditions, we cannot treat any other mental illness until we treat the addiction, period. That's why we're bringing this to the forefront first. If we don't get people clean and sober, we can't treat depression or anxiety or psychosis or PTSD or any other mental illness. That's how important we believe it is.
Thank you.
So,
Karen?
Switching from your very comprehensive, wonderful presentation with the emphasis that you've had to our problem, which is to try to think creatively in a slightly different way. Like, what would it take to build the kinds of preventive and clinical services that would improve the health of Vermonters? So doing that approach and starting with an emphasis on prevention, which you mentioned would certainly be one of the shifts in current funding you'd like to see, and then building in clinical services and then specialty services, sort of the birthday cake
The pyramid, yeah.
of the future. We have on our Act 48 required things that we're going to be working on to do things like a global budget for health and looking at ways to prevent, to do prevention. If you were to be the one to do this birthday cake building, how would you go about doing it? Because right now you're sort of caught between CDC project-based funding for binge drinking, and then that runs out. And then you
Yes.
might get some HIV prevention money, and that might help bring in the substance abuser, and so forth. So that's really a very important but responsive kind of behavior on the health department's part, which is what health departments do to stay afloat. But here, the conversation, like you started to do with your blueprint integration diagram, is really looking more at the needs of the Vermonters. But in a sense, I don't see where the corresponding fiscal argument or case is for doing that. And I'm wondering, is that anything that you're talking about? Is there something that we could help to facilitate? Because it would be a very good way to think about the alignment of things like incentives if we knew what the vision for the future is for mental health and substance abuse and behavioral health that had it right.
Oh, that's a complex question, and I would say I think a worthy one that we would welcome coming together with the blueprint and continuing. I think we've started with the opiate dependence because that's been a particular challenge, but looking at how we do more together with prevention is absolutely on the radar screen. How we do that in the context of healthcare reform, I think I'm just beginning to understand what some of the opportunities might be. We have tended to use the public health model, so it's based on a community needs assessment, and then communities actually using evidence-based strategies to address the need. And I think that is a great model to look at in whether it be the hospital areas or whatever configuration we're talking about. What are the needs? I mean, we have data at all these local levels that we can actually provide and look at, and then look at setting up strategies to reduce, et cetera. So I think it would be the basic public health approach. What we haven't had is the right configuration of people actually working together as you point out, we have this group that works over here on this subject, and this group that works over here on this subject, and this grant that does this. But I think under healthcare reform, we actually have an opportunity to bring communities together more broadly to look at some of these intractable problems that we're all struggling with, and to ensure we have comprehensive strategies. How you put that together in terms of the funding and reinvesting some of the savings in broader prevention strategies, I think is an important conversation to have.
Just to follow up, as part of your survey of people to look at
Yes.
ADAPT and the integration questions.
Yes.
Can you tell us a little bit more about the background to that and what the hope of it is? And is this a piece of going in that truly
Yes.
more integrated direction
Yes.
beyond substance abuse? And
If I might, I
No.
want to turn to Marcia LaPlante, who's our prevention chief, and she has been working with our contractor around the design of the strategic prevention enhancement and the future planning. So, Marcia, would you like to maybe step up to the microphone? I think you need to come up here to do that.
So, the interview to which you're referring, thank you very much for taking the time to
It was a
participate.
good learning experience. too.
We have a small grant from the Substance Abuse and Mental Health Services Administration to help us get from point A to point B. Barbara described a very large pilot project of which we've been a part nationally for the last 5 years, and we got some significant outcomes from that. Now the money goes away, and we're looking at how can we do the very best we can do to sustain the things that we found worked the best in that study. And we know that 2 areas where we really want to improve are how do we define prevention services in terms of healthcare reform, and how can we structure things in a way that are most user-friendly for the system. The other thing we're looking at is how can we partner differently with our peers in the intervention and treatment and recovery fields, so we're getting absolutely the most bang for the buck. We're trying to think out of the box a little bit, and that's why we appreciated so much you participating. The stakeholder interviews will be compiled, and that will be part of the information that a planning team utilizes in April to come up with some recommendations about where they think we most need to be over the next 5 years.
Yep, that's great. So I know we're over time.
I just
and
wanted to make one comment on the
Yeah.
prevention. I hope that that doesn't get lost, given the lost funding, that's an area where we can figure out how to backfill. I grew up in Vermont, and I know what we did from about age 13 on Friday and Saturday was go drinking. And now I have a son who's living here in Montpelier, and I see he actually can go on Friday and Saturday nights and play basketball at the rec center, and that facility is just falling apart. Ken knows, he's been there a lot. And they're having trouble keeping lots of programs in the schools that would give kids interests that they might be pursuing on Friday and Saturday night, other than the usual. And I think if you look at the map, one of the things, I'm not saying it's the only thing, but one of the things that those northern states have in common is that it's pretty dull. And if you're a teenager looking for a thrill, it's hard to get a thrill.
Yeah.
And so thinking about ways to connect with the schools, and I assume that that's part of what's been done with those funds in the past, but ways to backfill that and make sure that there are some things that kids can do, I think is really important.
Absolutely. Well, I'm heartened to hear your interest in looking at how we do a better job in supporting the prevention aspects of it's very easy, and we all do it. I mean, when there's a huge problem, we go to the problem because we have to take care of it. But our young people, you know, we want them to be healthy and well. And in public health, that's what we're always trying to focus on, is what do we do to create the community structure, as you're pointing out. You know, if we don't know how to do things in a healthy way, if we don't have the opportunities to practice healthy behaviors and get reinforcement for that in the community, for doing good and for being productively involved, it's really easy to find reinforcement in some of the negative behaviors that people get stuck in. So as we heard earlier, you know, it comes right back down. If we want people who are healthy, productive adults who can carry a job and you know, be part of the community, we have to teach them how to do that. And that's really what prevention is about, including the health aspects. So I want to thank you for your time today.
It's very
and
helpful.
There's a few more things, but I think we actually got to all of them. And if you have any other questions, I'd be happy to get you more information as you need it.
Thank you, Barbara. All right, at this point, I think we're going to invite Dr. Rhee to come up.
You do not have a handout from Dr. Rhee. Will be giving that after the presentation.
Okay. Do we have the presentation on the?
Right there.
It's right there.
Can I pull one of these?
Yeah, both of them.
Both of them? You sure?
Pull anything you want.
If Lori says it's okay, it's
This one was
okay.
our website, and this one was hers.
Oh, okay, cool.
2 out of 4 of my best friends from high school ended up in jail.
Is that right?
Yeah, I remember. It's stupid.
Say Gwen. Of course you can. What if any of the lobbyists here are
Go talk to PJ.
By the way, so you do this here, Billy Young.
Yeah.
Yeah.
Yeah. Sort of stretch.
Yeah, isn't it?
Yeah, I think so. It's good. No. Just try to save papers.
I do, yeah, you're on the list.
Barbara, well, I heard you were presenting. The choice was to Sunday.
Okay.
Sunday about the back 40.
Dr. Rhee, welcome back. So this presentation is an outgrowth of a conversation that Al and I had with Dr. Rhee. I'll let you there's your title right up there. Dr. Rhee is Vice President for Integrated Health Services for IBM and came to talk with us about IBM's interest in health reform, their involvement in health reform at various levels, and some of the things that they've been doing in their employee health plans, employee health programs aimed at improving the health of their employees or maximizing the health of their employees. So we invited him back to talk mostly about that subject, but anything else you want to talk about?
Great.
And thanks a lot.
No,
Welcome
thank
back to
you,
Vermont.
guys. And I apologize, we're IBM, so everything's kind of IT, and we don't have any handouts. But I feel uncomfortable because the slides are there, I'm here, so I could.
We can all go sit with Lori.
I can orient myself a little bit so
Don't
you're
twist my neck.
looking at the slides and looking at me at the same time if you want, so that's okay.
Only Thomas will care. And he'll work it out.
But so yeah, I wanted to thank.
over here, Al.
Yeah? Yeah, what are you doing?
I'm used to having a really crick neck by the end of
All right, so I just moved. Peer pressure works.
You guys are awful.
You guys have no idea what kind of fortune we're going to go with those chairs. It's nice out here.
Oh, God. Good night.
So there we go. Change the model.
Thank you, take it away.
Yeah, no, so I'm appreciative of the opportunity to present to you and to talk to you about what IBM is doing in the state, what we're doing nationally, what we're also doing globally. I did want to share, I was listening to some of the work in terms of the work that you're doing and the topics that you're focusing on. I'm a primary care physician. I'm trained in internal medicine and pediatrics. I worked in community health centers at FQHCs in DC and in Baltimore for a number of years, and then also worked in the federal government at HHS as the Chief Public Health Officer for HRSA, which of course is an agency that you were referencing some of the funds from ADAP and other sources. We have the Maternal and Child Health Bureau, the Community Health Centers, the National Health Service Corps, the primary care workforce issues there, as well as the HIV/AIDS Bureau. So I definitely am very familiar with the challenges as it relates to underserved communities, and now have been fortunate to be a part of the IBM team and looking at things from a public health perspective, but more the private sector, and also from a global perspective. So I did want to share some of the learnings. I've been at IBM for about a year right now in the role as the senior physician executive at IBM. And so wanted to share some of our lessons as well as hear from you how we can help you as you explore building a better health system. So if you go to the next slide, this is the broad overview of kind of the presentation looking at integrated health services, which is the division or the department that I lead globally, our vision, mission, our portfolio, the results that we've been able to achieve in Vermont, and then our broad kind of longitudinal experience with healthcare reform, with how we've looked at things from a design perspective, our commitment to primary care, which I know you're very committed to here with the blueprint and the different initiatives you're looking at, and also as you're building kind of this new system. Primary care I can tell, will be a very strong foundation for that. Health risk assessments, our healthy living programs, and how we've kind of felt like we've become a market leader in this space. So you go to the next slide there. This is our mission here. Oftentimes I think in the business community amongst employers, you really want to focus on things like performance. And clearly you see some of this. These are very common terms that the public health community uses. Things like healthy choices, healthy people, healthy communities, healthy workplaces. So this is our broad kind of vision within integrated health services, and this is part of IBM's commitment to its employees, its families, its retirees and their families, recognizing that the health of the employees is very much connected to the health of that community. And the role that we can play in partnering with that community is very fundamental to a basic value for IBM. And you can see here overall health, of course, that includes not just physical health, mental health, as we were looking at behavioral health. It also includes local and global health priorities. So clearly you have a local initiative now with the Green Mountain Board and the changes that are happening in Vermont. And we want to be able to meet those needs and priorities as they differ locally as well as globally. Safe and healthy work, and you can see here, designing health benefits and health promotion programs to increase quality and reduce costs, increase value, and supporting business continuity, because that is a very important fundamental aspect of what we do. We want to make sure if people are sick, it's hard to run a business, right? I mean, whether they're sick from their diabetes, their heart attack, or their depression, or a cancer that's been discovered, or a child who's sick or ill, or this is all connected to continuity as well. The 4 pillars here that we have, medical, safety, health benefits, and health promotion, are built on these other foundational principles of leadership, innovation, data-driven analytics. That's a very important piece of what we try to do. Evidence-based solutions, learning partnerships as well, and communication. And with a company like IBM that's in so many different states and so many countries, it is challenging. Cross-cultural communication is one of the most fascinating pieces of my job. In just a year, I've traveled to India a couple times, Japan a couple times, China, Philippines, UK, France, Germany, South Africa, Ghana, Argentina, and Brazil, and seen kind of the globe from a very different perspective. And really a lot of learnings from there in terms of how they built their health systems that have really been, I think, very helpful for us as a global team. If you go to the next slide, this is our broad portfolio of 50 priorities that we have that are in those 4 pillars of safety, medical, health benefits, and health promotion. So really a broad, holistic, kind of comprehensive approach in looking at these foundational principles that I referenced, like leadership, public policy, communication, analytics is here, evidence-based, partnerships, which could be public-private, innovation, talent, business support. But then you can see here we think very holistically about the spaces, making sure that those spaces are safe. Clearly in manufacturing, I was just in the site here at Burlington and looking at the environment, looking at the metrics and the measures that we have in place to make sure that those spaces are safe. And so here you can see A7 there. We also look at different services that we provide, and we all very much kind of behave like a public health agency, looking at responsiveness, preparedness issues, because we know, actually, especially when you look globally, there are a lot of natural and man-made disasters in which we have an important role to be proactive about being prepared and responding. And then our health benefits design, looking at how we do that, and really, this is about globally maybe $2 to $2.5 billion worth of voluntary spend that IBM has. So how we manage that to provide high quality at low cost is one of the challenges that we have, and I know that you have as well. And then health promotion, and you can see the different areas. Our foundation is these health risk assessments. So the recognition that not everything that a physician can identify as far as risk is just acquired through a blood test. Yeah, it's good to get a cholesterol, it's good to get a blood pressure, or it's good to get, some other kind of biometrics, BMI and such. But there are a lot of other behaviors, as we know. If you look at determinants of health, 70% of health outcomes is related to these broader determinants of environment and behavior. And so asking questions related to injury prevention issues, or asking questions about behaviors like smoking or physical activity and nutrition, as you'll see later, in the employer kind of business sector, this is very common. About 80% of folks do a health risk assessment. And that's part of connecting that with health claims data is very key to understanding your risk and also understanding what initiatives you should be providing. As you can see, being physically active, healthy eating, this is not only in terms of programs that you might have or the traditional thinking of a nutritionist, but also policies you might have in terms of food acquisition, procurement policies and things of that sort. Mental health, preventing tobacco, as we talked about, alcohol and drug abuse. I know the metrics of how many people are smokers. I know the interventions, how effective our smoking cessation programs are, nationally and globally. I also know how many people are kind of in this category of alcohol and drug abuse and such. So infection prevention, clinical, injury and violence-free living. So you can see, and engagement strategies has things like mobile health. We're very big now in technology and how we can leverage high tech, because often you don't have the resources to always do high touch. So you go to the next slide. So this is IBM Burlington with about 4,500 employees, the average age, and this is happening very much in the US. We're getting an older population. Look at the number of years of service. These are folks who've been really committed to IBM for a number of years, a couple decades on average, and then the number of lives that are covered, and we're self-insured in the US, and of course here as well. And that's the cost from last year. If you go to the next slide. Now this is a little detailed, and but this principle of primary, secondary, and tertiary prevention, I think we often, if you look at some studies that have been done in health affairs and such, and McGinnis has done this several times, where looking at the US, about 5% is spent on health promotion and public health, and we know how challenging kind of especially governmental public health has these challenges as it relates to trying to prevent where a lot of the funding goes to, which is basically in here, tertiary prevention, where someone has already had a heart attack or already had an amputated leg or already going blind from diabetes. And then also the primary care system often focuses on this in terms of early screenings and prevention from a secondary prevention perspective. But preventing those chronic conditions from occurring, thinking about how you build the system to do that primary prevention and health promotion is important. And so you can see here we have 80% participation in Vermont for IBM's healthy living programs. You can see how many folks have kind of engaged in physical activity, personal vitality. We have a children's health program that really looks at it from a more holistic perspective, not just the employees, but those children. And this is the reporting in terms of low-fat diet and vaccinations and also being physically active, which are very high compared to other kind of rates that you would typically get from like the CDC, Burfus types of studies and such of that sort. Also, we can look at claims data, and we can see how many people actually got screening for a broad range of different kind of HEDIS metrics on secondary prevention. And so here you can see our measures are typically much better than corporate benchmarks, and then also much better than the general US population. So we track this very rigorously as part of our data-driven analytics approach. And then, of course, tertiary prevention is always important, and that's where, frankly, 80% of your healthcare costs go to that, as we know, and that for about 20% of the population. Is there any water? Probably not. Okay, I'll just try to rustle through. If I could, thank you.
Lucy's gonna get some.
Yeah. If you go to the next slide. So this was a challenge, and this was part of what IBM saw close to 10 years ago. They were seeing that we were not doing well as we benchmarked with other similar employers in terms of our healthcare costs. And we were very concerned about how costly it was, how we weren't thinking population health, how we weren't thinking about prevention and primary care and chronic diseases and things of that sort. And as a result, there was a real transformation that IBM went through in 2003 to sort of confront this challenge. And if you go to the next slide. At that time, there was a strategy, healthy people for high performance. Once again, resonating with this concept of performance, which often resonates within the business community. The fact that, and we know this in a lot of studies, like diabetic is not as productive or high performing as a non-diabetic, or someone who's obese, or someone who's depressed. You can go into all of these different kind of conditions and see that there are definitely aspects of performance as well as productivity that have implications. So our strategy has had this thinking and investing in the productivity and innovation of people and the importance of partnerships such as those that we're trying to engage and discuss with you and the Green Mountain Board as well. So if you go to the next slide. So this is kind of the foundation of what we've done, and we've presented on the Hill and other places on this strategy. But commitment to quality and prevention, employee-centered, foundation in prevention and primary care, and also being a voice for healthcare quality. Sharing as we notice that things are changing, whether in Vermont or in the nation, sharing some of our thoughts, our principles, our basis, and our successes, and sometimes our failures as well. So you can see that we've kind of done this through different initiatives that are employee-centered, focused on prevention and value in medical care, incentives, and promoting healthy living programs and healthcare quality. We're very, from the analytics perspective, very very precise and persistent about measures and actually looking at the insurance providers to help us improve those measures and saying and even putting funds at risk if they don't improve those measures, which I think is really what we often people talk about, not a pay for quantity system, but a pay for performance or quality system. Go to the next slide. So in 2004, and there's just a little bit of chronology here, the trend that we had started to improve as we made major changes, including shared responsibility, increased transparency. A lot of times employees don't know the costs that really an employer is investing in their health. And having more transparency often creates some, hopefully, smart decision making and thinking. So we did a lot of that early. Disease management, healthy living programs, and focus on the big ones like smoking and physical activity at that time. And then we started to continue to evolve it every year with different initiatives that we added and we kind of compounded to the initial kind of changes that we did in 2003 that started in 2004. Before the Affordable Care Act came into play and it created this kind of 100% coverage for prevention, we did it internally. We actually did it for primary care as well before it was made into law. So you'll see some of these kind of initiatives that we did, which I think in many ways are in some ways a blueprint of some aspects of the Affordable Care Act. If you go to the next slide.
You can take a water break.
Water break, thank you. Oh, that's so generous, appreciate it. So, one thing we did very creatively, which I didn't know we did, I was like, wow, that's cool. 2006, we brought the 4 physician societies together in a meeting. Now, in my opinion, primary care and medical home, it's an old concept. It's this, I was like, this stuff, medical home, the pediatricians thought of it a long time ago, 40 years ago, Calvin Sia from Hawaii and all these folks. And also I love, I don't know, do you know the 6 C's of primary care, which is like continuous, having a continuous relationship with a provider. Comprehensive, thinking about the whole person, not just their organ system or their disease. Coordinated, working within a team. collaborative, working also within a team as you've got these community teams in place. Community-based, thinking within the context of the prevalent issues in your community. So my point is, primary care has been known for a long time. This is not something new. But, of course, like many things, to get it appropriate attention, you've got to bring people together and try to systematize it and try to make it something that's measurable. So we brought the 4 physicians, these are the family physicians, the pediatricians, the internists, and the osteopathic docs together, and they came up with the joint principles of the medical home in 2006. A very thoughtful and creative thing that I think IBM did kind of to create that space, because we were sort of saying, you know what? We're tired of this restaurant of healthcare where we keep on getting hamburgers. We sort of want grilled chicken. We're paying for this. Can we change it? Can we get folks to think differently? And clearly these guys help provide some of these principles that were actually old principles. So go ahead. So 2007 to 2009, then trends you can see here once again, and then we really kind of elevated behavioral health more, and really recognize that a lot of these costs, these issues that we're seeing are behavioral health related. We've got to be more proactive about covering behavioral health and care coordination, of course. We started doing pilots then and challenging our insurers to do pilots. And we often have like an innovation fund, a quality innovation fund with all of our providers and insurers, whether it's Aetna, United, WellPoint, MVP, or health partners. We have 5 broad ones nationally. And we started seeing results from those pilots as well, and you'll see some of those later. And we started really expanding children's health programs, women's and men's health, and then generics, which is very important. And also our strategy for specialty medications. If you go to the next slide. This was another thing that built on that meeting of all of the physician groups. We created this group called the Patient-Centered Primary Care Collaborative, which actually brings all the diverse stakeholders, especially employers, but health plans and patient advocacy groups, and have these places, these hopefully safe places for people to talk, exchange ideas, and really build more of this broader evidence on the effectiveness of primary care and the importance of it being fundamental to what we ask in that restaurant, that we need to have more choices and healthier choices available. And I think this is a continuing work that we have and a continuing commitment from IBM to kind of cover that. What's great is we initially covered it ourselves, and then now other groups are covering it. So now in many ways the business community is paying for this kind of initiative. Next slide. So 2010, 100% coverage for primary care introduced, integrated pilots, new coverage for nutrition for all members, and then you can see the trends. We added things because we're noticing things like musculoskeletal health, migraines, healthy pregnancy are major issues. And then in 2012, what we're looking at more is global health risk assessments, this concept of digital health coaching, where we customize the health risk assessment to someone's risks, and it's a high-tech solution, which hopefully will have a mobile health component, so you don't need live coaches, which is a challenge, and you can use the live coaching when you've got more complex cases and situations, and new collaborative relationships and innovations with our medical providers and our pharmacy providers, and really focusing on things like preventable ER visits and hospitalizations. And of course, we're always open to public-private partnerships, and that's something from my own public sector experience. I'm very interested in ways in which we can engage in that. If you go to the next slide.
So can I just stop for a second?
Of course.
Because I'm interested in that timeline, and I can imagine a timeline that goes from 2012 forward, and the trend at the bottom is healthcare spending in Vermont. And we're introducing interventions each year that we think are having some impact. And we need to assess whether they're having an impact, and if so, on what. Are they lowering the price of things? Are they substituting services? Are they having an effect on utilization? What's the right trend? How do we compare ourselves to benchmarks? So I'm interested in how you guys do that kind of evaluation, not just of discrete programs, but of the whole enchilada, and make sure that you're getting good results on the bottom line.
Yeah, so we typically will do modeling based on what we estimate the trends would be as we compare ourselves a little bit apples to apples to another large employer. So when that trend, you'll see in a later slide, you'll see a big number, 1.7 billion saved over 8 years. And we compare ourselves with other large employers nationally who experienced similar kind of, or a certain trend, and we saw how we compared relative to them. And so we could help, I mean, we basically model it out. And we also, look at each metric. Like, I love looking at the HEDIS measures and see how we went up on flu vaccinations, although recently the rules changed on that, so then we sort of dipped because the evidence changed. And we see that in mammograms and other things too. So I think having that dashboard is very important to hold yourself accountable. But making sure that the dashboard is not just quality metrics, but cost metrics, because that is the big problem in the system, is people know there was a study in Health Affairs that said all the raises in the last 10 years for US employers went to healthcare costs. There's no raises. I mean, so because of that. So it's very much a jobs issue, healthcare costs, as you know.
Can you just explain the percentage and the trend? Make a sentence out of that. What does 4.7% mean that year?
That's our trend for medical costs. And we went up in 2011, when we looked at 2011 costs, it was 4.7 above 2010 costs for medical costs.
So the trend of 2.8 was built on whatever the expenditures were in 2010, and then there's a higher baseline in 2011's compared to the expenditures in next year. So the baseline has continued to rise because every one of the numbers has been positive for every year that you've shown.
Yeah, I mean, we're not saying we're going to decrease healthcare costs. We're talking about bending the cost curve, which is what,
But as I look across, it's pretty variable year to year. So in fact, have you bent the cost curve? Because just looking, it's just sort of up and down within a range.
So can you go a few slides? I'll show you, because you're asking a good question. Go forward. I mean, no, go the other direction, sorry. And I'll show it to you, right? So to answer your question, go forward a couple more. Go on one more. Okay, actually go back. Sorry. So this is hard to see, and this is the red, this is the benchmark. This is the increases that companies similar to IBM, with some sort of similar demographic profiles, experienced, the red, and from 2003 to 2011. The blue is what we experienced. So look at that. I mean, obviously we got some benefit there. Here we were pretty much the same. Here we were a little worse. Here we were better. Here we were a little worse. Here we were better. Here we're better. So you can't, I mean, healthcare costs are very variable. I think it's pretty predictable that it'll go up. It's pretty predictable that it goes above, the rate of inflation. But beyond that, yeah, there were years we didn't do as well as our benchmark, but there are years we did well. Now, if you add this all up, over 8 years, it was 1.7 billion.
Less than the benchmark.
Yeah.
Yeah.
And you'll see, next slide, if you go to the next slide. That's the average trend, 4.9%. So before we made these thoughtful changes in 2003, so our rate, this is including medical, dental, and vision. The prior one was just medical. So just so you know, a lot of the design and thinking was around medical issues. We didn't do as much, frankly, in dental, oral health, creative promotion, healthy promotion, or in vision, health promotion. I mean, a lot of these are related more to direct medical costs, right? So if you go to the next slide, this is sort of the 1.7 billion.
And you include in your calculation of total costs, you include the cost of whatever interventions you introduce?
Yes.
So what I'm seeing is that if Windows 87 was Apple 76, Green Mountain Care Board 2012 is IBM 2003.
Yeah, I mean, you could say something like that, maybe. Anyway. Okay.
So we're
Steve Jobs.
No, we're behind you, but we're on the right path, is what I'm taking from this. If we're on that same path as you, and I know that'd be a big statement for you to make, I'm not putting you on the spot.
Yeah, I mean, I love you guys, so I don't see any reason why you
can't.
can't. But I mean, obviously the decisions you make are major decisions for the future. So I mean.
No, you understand
Yeah,
what I'm
and
saying.
obviously,
We got to hear what the rebates are to incent the behavioral change.
Well, some of it is, yeah.
Well, we can go into that.
Yeah.
Go all the way back to the.
I know, I heard that $300, but,
Go back.
It's not really
Yeah, but it's to me it's okay. You can go to the no, not that far. Sorry. So much
That's all right, that's all
so
right.
much fun to be like.
yeah.
So if you go a couple more slides forward.
Forward?
Yeah.
Okay.
And then we talked about that. We talked about that. Go to the next. Okay. So this concept of medical home and primary care, which gets a lot of press, I just can't underemphasize it in how it's been very core to our strategy. Challenging folks to do primary care pilots, looking at the metrics of who people see actually, and seeing that, and also looking at our own kind of research that like there are major benefits from having people go to their primary care clinician or team, and you know this all, in terms of reduction in specialty care, ER visits, ancillary costs like imaging that can be repeated and procedures done, and specialty care and hospital reduction, and then a total cost reduction and an ROI. So we've been people initially were like, why would you want to do that? You're self-insured, you're putting no copay for primary care, and you're putting all these preventive services that are typically delivered in primary care and putting no copays. They were like, your costs are going to go. That's not what happened. Costs went up, but they didn't go as much as they would have gone, right? So, that's a consistent thing so my point is, the quick answer is to think, oh, it's the $300 that changed the behavior. It's broader than that. That is part of the equation, but it's also how you design and how you also challenge your healthcare providers to deliver what you want them to deliver. If you're in a restaurant, you don't like the food, you're paying for it. You can start asking for different ingredients in the food. You could send it back. You could say, I'm not paying for that. I didn't like it. You didn't give me what I wanted. So you have to start to have that type of approach. Go to the next slide. This is about health risk assessments.
You don't like all these metaphors.
Like food on sugar on a cup.
He wanted to be in the restaurant business, and I wanted to get into healthcare, so we
All
swapped.
right, well, let's swap. Yeah, I hear your business is going pretty well.
It's going well this week.
All right, so health risk assessments, 80% do a health risk appraisal. These are US companies. And about 76% use incentives. All right, so, and you can look at what the average incentive is about $300. Although another study showed the average incentive was like $740. This National Business Group on Health. And then almost half of them offer them to dependents. So this is very typical. It's like money that's spent in incentives, you think it's a net sum loss, but actually leads to also changes in behavior that we've seen and decreased claims cost. So, and I think, like I said, it's not just about the money. We get participation, I mentioned, about 80%. This is a voluntary program. This is not like a requirement. It's a pretty, I'm not saying that $300 doesn't help. It does help. But, what I've seen in places like India, when we do some things like this, there's a 75% kind of rate of compliance or adherence, and I'm like amazed that people want to know about their health and like to start thinking that when they go through this, it's more than just getting a blood test. It's about these other things, because it doesn't take much to start realizing, oh, these are the questions they're asking. This must be connected to other aspects of health. Next slide. So this is sort of what we've done. This is just a broad overview of the high-level programs. There are a lot of other programs here, but I just wanted to say the evolution that we've had from 3, starting with smoking. The health risk assessment has been the foundation. Physical activity, nutrition, preventive, children's healthy pregnancy, vitality, migraines have been added. Next slide.
Before you go forward, can you go back one, we talked one more, the incentives, but to the penalties, and just talk about those a little bit. And there's a recent article, I think it was in Health Affairs or JAMA, like last week, on the problem with the penalties in terms of people actually dropping out of care as a result of penalties.
What do you-
It was a RAM study, that's where it was.
So you mean?
In other words, when the penalties, they were not a disincentive that led people to go for the incentives. They basically did the wrong thing and either didn't get the care they needed and certainly didn't go for the incentive programs. So by studying that particular group of the people who were suffering the penalties and what happened to their health got worse.
Yeah, I don't know the study. I will tell you the way this world has been framed in terms of incentives is carrots and sticks.
Right.
We have more of a carrot approach.
It looks like everybody does, except around smoking possibly.
Yeah. Yep. Typically, that's the case. So, and also some folks say, you like this metaphor too.
Yes, No, just wait.
A carrot, could be a frozen carrot. A frozen carrot's like a stick, right? I mean, at some point, if you get the benefit by doing the program and I don't get it, I don't know. It's sort of, to you it's a carrot, but to me, I'm like, why does she get the benefit and I don't? It's another way to frame it. The frozen carrot. It's just funny how. But yeah.
Have you ever, just in terms of that carrot and stick, have you ever surveyed, maybe even anonymously, your employee group about, this all evolved over the time when jobs were premium. IBM's got the biggest stick in the world, and that's job security. Nobody wants to lose, from 2008 to 2012, nobody wants to lose their job. Have you ever looked at that as a potential, incentive to do these programs rather than even money? A job in an organization like IBM is so valuable.
But they don't lose their job if they don't do this.
People are worried about their jobs in every way,
Yeah, but there is some huge aspect. I mean, we're very particular about privacy. We don't have access to this information. This is a third-party vendor that analyzes it all, connects the claims data with the health risk assessment data. There's no job insecurity related to doing this or not doing this.
But I do think in another way though, Alan, that IBM's demographic is a very unique demographic. And so the question would be, do they get a score that's higher than some other population, based on, age, educational background, the engineer population? Are they more likely to do something like this? Things like that.
Yeah, we are. I would say we are more nationally and globally. We're more educated. I mean, I know the role of social determinants of health. We are typically more literate. So it could be, you could definitely say that this is more predisposed to our population. But I wouldn't go and say, having served in underserved settings, that you couldn't use this tool in that setting too. You could. I wouldn't be like elitist about it and say this is just for highly educated folks. So, and in fact, if you look at the broader scope of U.S. companies, this is IBM too. We have a broad spectrum of employee types. It's not just the graduate school educated folks or whatever, So, all right, so go to the next slide. Next slide. Okay, so here's typically, and this is kind of in the wellness field, like D. Eddington is kind of the father of wellness in many ways, talks about how it's like a pyramid, and unfortunately the pyramid's becoming more like a circle or something, because right now low-risk folks are here, and medium-risk folks are here, and high-risk folks are here. And typically your healthcare costs of 80% are here. Part of the problem or the challenge that we have is these people will always be replaced as people trend. Typically 2% a year of people in this category go into this category. So you have to have a preventive approach. We often focus on these folks, trying to help them reduce healthcare costs, but you've got to now think about these guys. And have a broader population health approach that prevents these guys from going up here. And we've done that. And in fact, instead of a 2%, these are longitudinally following the same people or similar people, even though the numbers are a little off. This is looking at how our shift would normally go 2% up here, but we've actually gone in the reverse direction. So that's a reverse like 9% or something like that. So the point here is that you can move people from here to here, or you can prevent people from going here to there. And so, and this is what we do in the annual health risk assessment to assess those other factors. I mean, these are factors like stress, smoking, physical activity, nutrition, injury prevention, seat belts and all these other, there's a broad range of questions that are asked. And I think from a population health perspective, it would be great to have all employers in Vermont ask those same questions so we could sort of aggregate the data together. And people can start seeing things more than what we typically do in the biomedical field is just focus on cholesterol levels and blood pressure levels and diagnosis codes and things. And then the other thing we've done is we connected this to reduction in healthcare costs. So this is aggregate. So it's direct healthcare costs. So after 6 years here, $134 million was saved in terms of moving these folks down from and now this doesn't even include other costs. I mean, business costs, we typically think of absenteeism. If someone's sick, they take days off from work. Like in the US, I think it's an average of 5 days or 6 days off from work a year. Now, if you reduce those numbers, that's something of value, right? You don't have to cover, you can, that's productivity. So also presenteeism is another concept, which typically is like 4 or 5 times more valuable than absenteeism. When you actually prevent chronic diseases, I mean, we should get credit for that, but we often don't in a pay for quantity, pay for illness system. So, but you can also quantify this, and this was a very conservative estimate of presenteeism when you prevent these folks from going into that category. Next slide. This is now how the benchmarks have changed since then. So you can see we got better compared to the benchmark, which is the light blue. So we're not saying we're, overwhelming, but as you can see, when you're talking about nationally, at least a few hundred or 400, 500,000 folks covered, difference of $200 makes a big difference, right? It adds up. And then comparing it to the benchmark. Go to the next slide. This is the trend. This includes medical, dental, and vision. So that's why these numbers are different from the other ones, which were focused on medical. And generic. This was big. This was huge. Increasing that generic utilization is very important, and you create incentives and disincentives to promote that. Because we know that it's the same ingredient. And actually now with a lot of drugs going off patent, we're really promoting it even more. Because typically, good 25% of your spend is related to drug costs. And in fact, from our perspective, we want to increase that as well as primary care utilization because we know it'll lead to lower ER, specialty, other procedures, and hospitalization costs. So we're fanatic about looking at chronic conditions like asthma I was talking about yesterday, inhaled corticosteroids. People who have persistent asthma, what is their rates of compliance, adherence? And same thing with heart disease, beta blockers and other things. So we're very big on looking at those metrics and then challenging the healthcare providers that we pay them to deliver the care to our employees to improve those metrics. Okay, next slide. So this is that 1.7 billion and how it's sort of in the past 8 years. And this was modeling by Towers Watson to look at that. If we had left things alone and never made any changes from then, these are the anticipated costs that we would have had. Okay, next. So here's just a broad overview. High performance through healthy choices, people, workplaces, and communities. Primary, secondary, and tertiary prevention. This is often forgotten, primary and secondary. We know from health disparities that a lot of folks get diagnosed at late stages of illness. They get diagnosed with diabetes. Half of all diabetics approximately, and a third of hypertensives don't even know those things, right? So then they go blind or their kidneys are failing, and then now suddenly they get diagnosed. Or a woman with metastatic breast cancer gets diagnosed. That's a huge cost to the health system. So thinking about how you weigh these more, evolution for high quality and affordability, innovation, prevention, primary care, you can start engaging with health care providers, which I didn't know. I didn't know as an employee that, in some of these negotiations with these big providers, you start putting innovation in the metrics. Or in fact, when we do our RFPs, we weigh quality and innovation higher than cost. Health risk assessments and reducing costs, and then the 1.7 billion. So next slide. That's it. All right, thank you.
Thank you. So, what's that? Yeah, I want to make sure everybody gets a chance to ask their questions first. And Al and I have to run down the street, unfortunately. Karen, can I ask you to take over and just make sure we do the public comment? Yep. Okay, before we get to public comment, and before Al leaves, do you have a question?
I actually was lucky enough to meet with them yesterday, so I got a lot of questions, and I just want to thank you.
Okay,
very, very
Anya,
much.
do you? Okay, Al.
Thank you so much for
Alan,
No, thank you guys.
wherever.
Alan?
I'm just trying to think about how to translate this into, part of the metric for the patient-centered medical homes for all the non-commercial people that we say that to and the publicly financed healthcare. It gets really complicated. You work in community health centers and we all want this well, I know I'm not surprised at all about the trends you see. It's just so logical. Put in health living programs, and you're going to see decreasing costs. You improve quality, decrease costs. But we've got a lot of other kind of groups that we don't have quite as careful a control of.
And this, having been in community health centers and seeing that from HRSA's perspective, $600 a person a year is for primary and preventive care and all the labs and even medications with the 340B program is a bargain. So I'm a big believer in the role of FQHCs and actually you can do cost-effective, high-quality interventions by supporting those systems of care like community health centers. So but I do know from being a primary care physician in that setting how overwhelming it is. I try to put in buprenorphine programs and other things. And from the RAND study, they're overwhelmed right now. They've got 15 minutes to do a visit, and they've got to spend half of that time documenting the visit. So they got 7 or 8 minutes with a person to talk to them about the broad issues that they have. It's a very challenging. But if you create these teams, and the engagement isn't just about the provider, but the broader team, and you create payment models that actually help reimburse that, and if you start looking at, I was asking this yesterday, if you start looking at your costs, your spend, your healthcare dollar spend, how much of it is related to really primary care and prevention? How much of it is more on intervention and treatment? You sort of need to get that percentage of primary care and prevention higher. You sort of have to figure out a way to do that.
Do you ever think about down the line looking at overtreatment issues in your employee population? That's really, there's a tremendous amount of money in that overtreatment. Whether it's antibiotics for sinus infections or unwanted critical care at the end of life. You've got overtreatment waste in the system that is phenomenal. Do you envision a time when you're in your position, you can start looking at the specialty side of stuff rather than just the primary care side of stuff?
Yeah, we do look at that other side. We actually created some disincentives for people going straight to specialty to go.
But when they get to the specialist, disincenting the specialist for overtreatment, which we see all the time.
Yeah, I don't know about that. We don't typically have a stick culture, I would say.
Right.
What you're implying is that I think though we do, to me, the biggest, if you're looking at the bang of overuse, people who have a cold going to the ER, that's a poor use of resources. So preventable hospitalizations, which we know is like a third of them are preventable. So we start looking at those metrics and saying, how can we reduce this? How can we promote amongst the employees that they should call their clinician? Or when you have that advanced access, 24/7 coverage, they're calling them first before they go to the ER. We're not here to, and then preventable hospitalizations too, readmissions and all that. So to me, the biggest 2 bangs for your buck is to focus on the ER visits that are preventable and the admissions that are preventable. But we're very preserving of the doctor-patient relationship, and to get in between a specialist and a provider and say, you can't order what you think you want to order. That's a little awkward. Now, I think what you're mentioning is a reference to redundant tests and things. Is that what you're talking about? So.
No, it's just that there's no disincentive on the specialty side to not do everything that is related to everything in a fee-for-service system that's over-treated.
Well, I mean, in some ways,
There's no disincentive now, but you're dealing with a healthy population. We're looking at the entire population.
our population is older.
Yeah.
Actually, there's a lot of cancer. We have about 10 to 15% rate of cancer prevalence in our population.
So let me give you an example.
I mean, I wouldn't say we're healthy.
You've got a patient with an IBM with heart failure, and they're being managed in the patient-centered medical home. Okay, and the patient-centered medical home has good, quick intervention for those, that early identification of that exacerbation. The weight goes up 2 pounds. Okay, somebody gets notified in the home, something gets done, diuretics get changed. And that's good. So then the next thing that happens is that they become resistant to that early intervention therapy, like the diuretics. So they go off to the specialist.
Yeah.
Or the primary care person doesn't have a good integration with the specialist to do that early intervention that needs to be done to prevent the hospitalization or the ER visits. That's what
I agree with those challenges. I mean, we've got lots of challenges as it relates to specialists, and to me, specialists are a big part of the primary care team, and they should be more integrated. And primary care teams should be able to integrate them and help coordinate their care, going back to the principle of primary care. I think we have a really tough system, though, because the systems have been put into place. From me, when I was medical school, I saw my colleagues, I said I want to be a primary care doctor. They're like, why would you want to do that, Q? That wasn't that attractive. It's like, well, I wanted to take care of people over a long period of time. It sounds relationships, not just their organ system. But they were getting paid 3 or 4 times more. They saw those numbers. And then the way in which we train healthcare professionals, they're in these hospital settings where tertiary prevention rules. And that's where a lot of their mentors are. So there's a lot of, and so we've got now 70% of internal medicine folks being specialists. We've got 60% of pediatric folks going into specialists. There's a whole broad range of challenging issues, and from a workforce perspective, GME issues and all these things. It's very complex. What's great about Vermont, you've got this kind of, you know everybody else who's the players and the stakeholders. I like to say if you're not at the table, you're probably on the menu. You don't want to get on the menu, so bring them all to the table. So you can bring them all to the table and start having this dialogue. And some of that is, I like also referencing the stages of group development. If you get the right people to the table, form the right group, then they'll storm. Fighting is okay. You got to navigate through those storms. People often are in turf battles and things. Then you norm, and then you eventually perform. So you sort of got to get, your role, in my opinion, as the Green Mountain Board is to bring those right stakeholders to the table, bring them all so that people don't feel like they're on the menu and decisions aren't being made without them. Go through the forming stage, then the storming, navigate them through that storm, and then norm it a bit, and then get them to perform. And then the last stage is mourn, because everything eventually ends.
Yeah,
But
I love it.
all right.
Tom, did you have a question?
No, I just was particularly intrigued with the benchmarking work that they've done, and it's going to be very helpful to think that through a little bit.
Yeah, modeling it too is really important, so that you can kind of point to today's work as success for tomorrow.
And others in the audience have a question or a comment?
Yeah, well, I want to make sure that there's a guest here, Bill Young, who runs Montpelier Farm. This is working our way back to the alcohol and addiction, but I would hate to see this session end without him having a crack at us.
Okay, thanks. Thank you.
Welcome. Would you like to make a comment? Thank you very much. Guess we're all staying here, so.
Okay.
Just get near a microphone, that's all Thomas cares about.
Okay. Thank you for the opportunity to comment today. My name is Bill Young. I'm the executive director of Maple Leaf Farm in Underhill. We're one of the nation's oldest substance abuse treatment programs. We offer medical detox and residential treatment to about 800 men and women each year. Most of them are Vermont residents, but about 150 from New England states and other states. About 150 from other states in New England and elsewhere in the country, and a smattering from out of the country. About 80% of our patients are state paid, Medicaid, and a smaller amount grant for the uninsured, and the rest are insurance and private pay. We serve about the top 20% in level of severity of addictions. The population we see in terms of they all do the whole cornucopia of drugs, but in terms of substance of preference, about 50% is alcohol and 50% is opiates. And of the opiates these days, 99% is OxyContin. And that's a change. Average age is about 34 for both men and women. I'd like to talk a little bit about demand and a little bit about the money and the system. We're seeing a record increase in demand. Barbara talked about federal estimates of unmet need, about 50,000 Vermonters needing treatment for substance abuse and addiction each year but don't get it. I do think it needs to be said that we certainly know that some of those folks, if it was available, wouldn't avail themselves of treatment. So you have to take those numbers of unmet need with, understanding that. But I believe, that said, I believe that the estimates of people who would access treatment but don't get it in Vermont by ADAP are very conservative. What we find at Maple Leaf Farm, and certainly the numbers regarding residential treatment, which I happen to know a little bit more about, we've found that advertising works. You have this much larger population of people who are in real trouble with substance abuse and addiction who aren't availing themselves of treatment. Well, we're not doing a great job of reaching out to them and encouraging them. A few years ago at Maple Leaf, we began spending a modest sum of money, $20,000 a year, $15,000 a year on advertising. And all of a sudden, our numbers began to go up, or referrals. And, I have patient directors meeting every couple of weeks. I meet with the customers to say, how are we doing? And the other day, somebody said to me, I was sitting there at home, drinking and drugging and, thinking I should do something, but finding all the excuses not to. And the radio came on, and I heard you saying, drinking and drugging and can't quit, call Maple Leaf Farm. So I thought, listen to that jerk. And I turned off the radio and I went into the other room and turned on the television, and there was your ugly mug telling me, call Maple Leaf Farm. And I said, I got up and called you, and here I am. Advertising does work, and for across the board of a whole lot of businesses, but it works for this population if people are encouraged to come in, and I think we need to do more of that to let folks know. We've done it in so many other areas in the state. Years ago, we changed the world for sexually abused kids, and we started with constructing a system, and gradually it's not. We have this attention deficit disorder geared to 2-year political campaigns, but this will be a 10-year or 15-year effort, but you can get there, and we changed that world with sexual abuse victims by making treatment available and then telling them it was available, and then it began to be reported, and the numbers went way up, and then they began to go way down. So it is possible to address significant issues if we focus on it in a small state like Vermont, which is what I commend you folks for doing. I think a little more helpful fact in terms of demand is that in a 6-month period from last April to October, which is when we started implementing an electronic medical record system at the facility and started with our admissions office, in that 6 months we handled slightly over 4,000 phone calls requesting, calling us about admission. Most of those folks are simply given information, referred to outpatient treatment, handful to a higher level of care. But 418 people were admitted, but we did not admit 356 people who were clearly eligible for the type of program we provide because we didn't have a bed. Talk about a mission failure. So demand has, those are numbers we've never seen in the past. Have to be quick?
Yeah.
Okay. So demand is huge. Let me just speak to money one little bit, and then I'll be on my way here. I do think we need to be encouraging evidence-based practices. Payments need to reflect the cost of providing care, and that we need to find a way to use data to drive good practice and to assess programs. And the state has most of the data, and we don't do a good job of cooperating to use it. I think in terms of the issue of money, and I'll cut this short. The state spends over $500 million a year on related to substance use and addiction. Most of it on cleaning up the wreckage. I think you folks have probably seen the numbers. Almost about 90% of it. I used to work in corrections and child welfare, River of Tears, and a lot of it related to substance abuse and addiction. You referred earlier to, I think it was about 80% of the corrections population involved with substance abuse and addiction. I was a probation and parole officer. I worked with those folks. Child welfare, about 77% of the kids who came into custody as a result of abuse and neglect came from homes where substance abuse and addiction was an issue. 31% of our health care costs, our cops, our courts, and corrections, just huge, almost $500 million that we're spending. And the challenge is, and I really think corrections and everything I read from other states is the low-hanging fruit. How can you, nobody seems to disagree, but how do you turn the tide when you've got the people in the jails and you have to spend the money on it? And a study that we did last year on over 2,500 people who came into treatment at Maple Leaf who had been involved with corrections showed that treatment worked and showed that it saved the state money. But it clearly said that rather than trying to fix it after people have been in jail, that it appeared to us from our data that the impact of incarceration overwhelmed the effect of treatment in many cases. And where the real savings is to get people into treatment before they go to jail. And you'll be much more successful, and where that population treatment saved the state a little over $2 million, if we'd gotten to them before they went to jail, we would have saved the state $16 million. So I really think using good data to generate practices and to drive that system in a way that frees up money to spend it on things that where the dollar goes a lot further and a lot more effectively is, at a time of short money, instead of looking for new money, is to try and find ways that we can look that we're spending money now as a state and that we can begin to turn the tide. And initially, you look at smaller things. We got to spend $150,000 on a grant last year to get people out of psychiatric beds. We said we'd get 60 people out. We got 146 people out of psychiatric beds. Probably saved the state $500,000 net. There's all kinds of ways to do that around the edges, and that's where I think we have the best opportunity to begin to free up money to fuel our system in a way that's healthy.
Thank you so much.
Thank you. I've been kind of rushed, but.
Do you mind actually just repeating your name so that we get correctly for our minutes?
Okay. My name is Bill Young, Executive Director at Maple Leaf Farm.
Bill, did you have a presentation here that we could have?
I can write up what I scribbled here on my written notes and get it to you. I'd be glad to.
And we could make it part of the proceedings of.
Yeah, definitely.
I'd be glad to do that.
Great.
Great.
Okay, and
Thank you.
a moment, because we do have to leave the room pretty soon, but would anybody like to make a very brief on this topic statement?
On the IBM, I was curious on how many people were temporary employees and if they got the same health benefits as the full-time. As someone who knows temporary IBM employees, they did not, but I was curious of what they do.
Okay, we'll forward
We'll
that
forward the
question.
question and ask. Thank you.
And if IBM is on their public healthcare system, would they have to do all that wellness prevention? Would they have to do?
And
I just have that follow-up
Peg,
with that is,
yes.
my name is Peg Franzen. I would say that, how many people at IBM can afford the insurance at this time? How many are participating, and do we know how many are not able to because the premiums have gone up significantly?
Okay, again, we will forward those questions and, yep, last word?
Yeah, the state of Vermont, my name is Ted Hoppy. The state of Vermont also has a self-insured system. And I was wondering if you're going to get somebody down from the state's system to compare it to IBM's. Because it seems to me that IBM does a lot more and gets better results than the state system. And I think we might want to analyze why the state suffers from not performing at a benchmark level. If that is indeed the case.
I will just mention that on March 29th, we mentioned that we're going to have the first of a series of conversations about benefits in Green Mountain Care. And in particular, some of the considerations for 2012 that we can begin doing will be to look across some current state programs, including that program for state employees. So.
But is there somebody in charge of the state's program? Probably.
The state's HR department manages the state employee health program, and I will see what the possibilities are of getting them to come in to talk about the state plan.
That's a good idea.
I just want to ask, are the presentations going to be up
All
on the website?
The IBM presentation, which we're getting later today, will be posted on our website. Our new website, though, to be clear, so gmcboard.vermont.gov. And all presentations are always posted there. I will apologize. The person who usually does that for us is actually going to be out of the office for a week. Foolishly, we're letting her take a vacation. So this one probably won't be up until next week, but all presentations are available on our website.
Will the old website be linked to the new website?
The old website will be linked, but actually everything from the old website was put on the new website for us. And it looks very similar, but all presentations are duplicated on both sides of this mountain.
If somebody tries to use the old website.
It redirects. Okay. According to a lot of them.
Yes. Great, okay. I think we do have to vacate the room.
We do have to vacate the room, thank you.
So we can continue next meeting or informally. Thank you very much.